Thank you, everybody, for inviting me, for allowing me to speak today. I'm going to talk today about Access First, the case for independent nursing practice in the community. So I speak to really not just as a nurse or a clinician, but or a public health leader, but as someone who has seen time and again the transformational impact of accessible, timely, and skilled care delivered where people need it most, which is usually in their homes and in the communities. I've worked for many decades in community nursing, but we are called public health nurses here, so we do clinical as well as public health. But during the COVID, what I did see was that people didn't get access to care, fundamental care that they needed to in order to actually live and be at home in their house. So I set up a company called RO Health, and like I say, over the decades in community clinical practice, I've witnessed how care delivered by expert nurses in the home can ease suffering, restore dignity, and most importantly, remove barriers that too often delay or deny care entirely. And this is always within, sort of a team of other disciplines as well. It's not just nurses alone, but in these models, the nurse then isn't just part of the care pathway. They are usually the pathway. They are the connector, the clinician, and the constant in the life of a patient as well. So today I want to advocate for a new opportunity to work as an independent integrated community nurse, available to be contracted by the HSE, which is the operational arm of healthcare delivery in Ireland, and to deliver responsive, high quality care in a way that meets people where they are, both literally and clinically. And this is in the same way as contracts are issued to GPs, to pharmacists, to optometrists, and to dentists in Irish culture. So I don't see it as a pipe dream. I see it as a practical, cost-effective and patient-centred solution to our growing access crisis. We've had many reports out recently, literally focusing on the GP and the fact that they can't knit them quick enough to go forward or 3D print them, you know what I mean, to actually do what they have to do. So we can't just keep doing the same. We really, truly have to change the model. So this is a practical, cost-effective and patient-centred solution to our growing access crisis. And I'm not asking for a new regulatory category or another layer of bureaucracy. I'm simply asking that we use the skills we already have in the system and pay nurses fairly and directly for work that they are more than competent to deliver. So much of the work that's done by other professionals, particularly GPs, could be done by nurses. But the way in which the reimbursements are set up are in such a way as that the GP is the gatekeeper and sort of has the monopoly on it in the community. I offer a model based not on hierarchy, but on access, responsiveness, and results. I am what I would call a deep generalist specialist, a concept that has been recognized and advanced by thought leaders across the world, and notably Barack Obama, Elon Musk, and Steve Jobs. I'm not putting myself into their space, all right, but I'm only saying that they think in a similar way. I don't have their money either, by the way. So this is what we call a T-structure professional, where they've very deep expertise at their base, okay? But they have a very broad, sometimes expert knowledge in the key areas. And they have the ability to synergize the dots and to see the whole picture, the whole person. And in this case, what I am talking about is the whole person and not just the disease, which we understand too, specialisms and specialists, both nurses, doctors, and others have developed over the years. And they were great at their time, but now they're missing the mark. They're missing the whole person. So examples in the deep generalist nurse and my position, it is in my case that I am that. I can see the chronic disease patient, the palliative care patient, the emergency responsiveness, and community health and public health and health promotion all at once. Crucially, I do not argue that every nurse must be an advanced nurse practitioner to work independently. I do believe we have a scope of practice and we're regulated to work and to be working at something different. I believe in a broad generalist specialist approach, being agile, flexible, and wholly responsive to the needs of the people that we serve, not the protection of the professions and the professionals. But let's address the challenge because there is one. Ireland, like many other countries, is still deeply professionally centric. We build models that reinforce status, not service. We have a monopolised gatekeeper access through the professionals such as GPs and others. So even when GPs themselves are overburdened and are actually asking for help. There's a real and understandable fear in some corners of the system that independent nursing practice will substitute for others, that it will be used as a cheap replacement, but that's not what I'm proposing. This is not a substitution. This is a supplementation. This is access augmentation. This is the nurse as enabler, not intruder, as partner, for the moment and maybe in time as competitor. Let me be clear, I'm not seeking to displace the GP. I am seeking to remove unnecessary friction in the care pathway. When someone needs a dressing change, palliative care review, chronic disease checkup, or even urgent symptom relief at home in a longer day and week, they should not have to wait until a referral is approved or an appointment slot becomes
30
available,
seconds.
or unfortunately, attend ED when there is no other service available. Not everyone needs a doctor or a hospital. Not everybody needs a nurse either. They should be able to call on a registered, insured, competent, and HSE contracted independent nurse. And the Health Act of 1970 allows for this to happen as it does for others. What we do know with the Healthcare Act and the contractors at the moment, they were all developed in the 1970s when most of the professions that are contracted were male dominated as opposed to female dominated. We have a Sláinte care strategy across the country, and we'd like to activate that. So I want to reimagine care, invest in models that work, and contract nurses who are ready and willing to show the way forward. Thank you.